Good afternoon from Milan, Italy for eCancer TV. We have come together here to discuss immune thrombocytopenia. Now, as you know, immune thrombocytopenia is an immune-driven disease that leads to reduced platelets for different reasons. A, for the reasons of increased clearance of the platelets, and B, for the reason of less production of thrombocytes by the megakaryocytes, probably through also a reduction of production through the antibodies that bind to the megakaryocytes. Now, today at EHA, the European Hematology Association Congress here in Milan, we had an interesting symposium that discussed hot topics in immune thrombocytopenia, and I would like you to meet my faculty that participated in that meeting. We have my co-chair, Jim Bussell from Weill Cornell University. Hi, Jim. Thanks for being here.
Thank you.
We had Howard Liebman from University of Southern California in Los Angeles. Howard, thank you for joining. And we had Francesco Zaia from University of Udine. This is also the first question that I would like to direct to Francesco. You were talking about rituximab use in immune thrombocytopenia, and you know, the first question that I want to be relatively broad on is, what is your treatment goal in the first place in ITP? So what are you aiming at?
So the goal of treatment in ITP is not the same in all patients. According to patient characteristics and the disease characteristics and patient expectation, we can have a palliative goal or a curative goal. For a palliative goal, we mean the avoidance of bleeding, so the way to keep patients with a safe platelet count. And
so what's a safe platelet count?
Oh, we can say more than 20, 30,000.
Okay. All right.
Can I disagree with that, just in the sense that I think that's true from our point of view, but patients often feel more comfortable if the counts are greater than 50,000, because then if something happens and the count falls, they have some margin of safety.
Okay. So would you say you aim at a platelet count of 50 to 100,000?
If I can.
If you can. And now you talked about a curative approach.
Yeah.
Is there cure in ITP?
Some studies with some agents show that we can look for this goal. And for example, splenectomy, which is very diffuse in many countries, allowed in two-thirds of patients to achieve a long-term response. We can say a curative effect.
May I interrupt you? Because we are talking about ITP and we are talking about different agents. Jim, can you just quickly reiterate the different agents that have been used in ITP and that you think are useful in the treatment of immune thrombocytopenia?
There's a lot of agents: steroids, IV gamma globulin, dapsone, anti-CD20 rituximab, the TPO receptor agonists, and there's many more.
Now, coming to rituximab, because you were talking about rituximab in immune thrombocytopenia, are there prolonged responses with rituximab?
Several studies show that this goal can be achieved with rituximab, and we have different results according to different studies, which show that 20 to 40% of patients can achieve this goal. And this difference is maybe because of the different selection of patients who have been treated with rituximab.
So 20 to 30%?
20 to 40 also.
20 to 40% of long-term remissions. Okay, but what dose do you use?
But we generally use the standard dose, which means the same dose that we use in lymphoma, 375 milligrams square meters weekly for administration. And
do you believe in the stuff of 100 milligrams per square meter that has been brought up, especially by the British people?
It was some years ago a smaller dosage. The 100 flat dose was investigated, but the results seem lower than with the standard one.
And tell me, when you use rituximab, are there any long-term adverse effects?
Long-term event effects can happen. In particular, rituximab can determine immune suppression. So we have to look to this potential side effect.
So immune suppression, you mean people are more prone to have infections?
Right, particularly because some patients can develop hypogammaglobulinemia. There can be a very prolonged B-cell depletions, and some infectious complications have been described, sometimes also potentially fatal.
I think that one time you see more hypogammaglobulinemia is something that Francesco started, which is when you use dexamethasone with rituximab. So you get more bang for your buck, I think, in both of our opinions, in terms of cure, good responses, but you get more hypogammaglobulinemia as well, at least in my experience.
Is that clinically relevant?
I think it can be clinically relevant. We thought it was 10 to 20% in our recent study, and then half of those were IgGs of 400 or less, and we did give IVIG as a replacement to some of those people.
Okay.
Part of that may be also the fact that although you think of corticosteroids being the same in the response, dexamethasone high dose is actually lympholytic for both T and B cells. And by its effect on T cells, it may amplify the B cell depletion by preventing the helper cells from reinducing expression of antibodies.
Howard, you were discussing a very interesting point at the symposium, and that is ITP by itself a thromboembolic risk factor? Can you explain a little bit what brought you to discuss this?
Well, as you know, in the original studies of the TPO agonists, both otrombopag and romiplicin, both of these studies had to report adverse events. And in the long-term extension studies, it appeared that about 6% of patients on these trials developed either arterial or venous thromboembolic events, which led to many people believing that they themselves might be prothrombotic. But subsequent studies, at least from two large national patient registries, one from Denmark and one from the United Kingdom, looking at matched controls for age and gender and other risk factors, they found that probably the relative risk of developing venous thromboembolism in patients with ITP is about 1.5 to 2-fold greater than the non-ITP population, and that even the risk of arterial thrombosis is increased.
So does that mean the risk is increased even if these patients are not treated?
And these registries included patients who were, let me emphasize, treated for their ITP before the advent and the approval for the TPO agonists. Now, there are many reasons for why these patients can develop thrombosis. But I think one of the most important is that ITP is an inflammatory disorder, and many of the responses to inflammation enhance the prothrombotic state. On top of this, many patients have ITP associated with other autoimmune disorders, so-called secondary ITPs, of which lupus erythematosus and the antiphospholipid antibody syndrome, which are prothrombotic states in and of themselves, can contribute to the risk. And then finally, there's surgical interventions with splenectomy and other surgeries. And there's the use of intravenous immunoglobulin, which has been associated in retrospective reviews with a significant increased risk of arterial events in particular, and some venous events. And that has led to a black label warning in the United States as stating that by the FDA that thromboembolic events are a risk with the use of intravenous immunoglobulins.
So let me understand this. ITP is a prothrombotic state, but we are actually increasing platelets with TPO receptor agonists. So does that increase the risk of thrombosis?
Well, where it really emerges is predominantly in the risk of arterial thrombosis. Now that we know that ITP involves a significant percentage of patients are the older patient population who have other risk factors for vascular disease, raising the platelet count to excessive levels or even normal levels would bring their risk of subsequent arterial events back up to baseline, if not greater. But I want to emphasize that in studies looking at whether the TPO agonists themselves enhance platelet reactivity, there's no evidence that they do, nor is there evidence that by increasing the platelet count within a reasonable safe range, do you increase the generation of thrombin as measured by D dimers. So the only point to make is that the recommendations today for the use of thrombopoietin receptor agonists should be maintaining a platelet count between 50 and 100,000 in preference to trying to achieve a normal platelet count.
So that's very interesting. However, if a patient on TPO receptor agonists, or for that matter on any other treatment, actually develops thrombosis, how shall we treat those? I mean, that can be tricky. The platelet count may oscillate around 50,000 or so, and then do you use low molecular weight heparins? Would you go for full anticoagulation, just prophylactic or so?
The only thing I want to add before Howard answers is that in the original trials, there would be people on the TPO agents, either one, they would develop a thrombosis, people would get worried, they would stop the TPO agents, and at least one patient died of bleeding when their count then fell back to less than 5,000. Okay. So it is a tricky issue. Sorry.
No, I think that's important. I believe that you can maintain patients' platelet counts at a safe range. And there's data from the cancer studies where there's thrombocytopenia that results from systemic chemotherapy or even myeloablative chemotherapy, that you can treat these patients safely, at least with prophylactic doses of low molecular heparins, down to about 30,000 platelet count. And easily you can, and safely you can use treatment doses of low molecular heparins for platelet counts over 50,000. And our general pattern is to treat these patients like cancer patients. We never put them on warfarin. We leave them on low molecular heparins, in preference because of their short half-life, and treat them for what would be the appropriate duration of time, maintaining a platelet count either with the TPO agonist or other adjunctive treatments in combination, of hopefully above 50,000.
Thanks very much.
Do the other 10A inhibitors, are they like the vitamin K antagonists in that you wouldn't use those oral agents either?
Well, one of the questions would be, and it's brought up in terms of the cancer treatment, is there interactions between the newer 10A inhibitors or even dagabatron, the thrombin inhibitor, and example Eltrombopag. But if you look at the metabolic pathways, in fact, there doesn't appear to be any interaction between Eltrombopag's catabolism and its excretion and the catabolism excretion of the 10A inhibitors. So you could probably use them safely, aware of the fact that the half-lives are about, well, I should say the half-lives are about 12 to 14 hours, and in a normal individual with normal renal function, about 36 hours for complete clearance of these drugs.
So you mean by that it could be reasonable to use those drugs?
It could be reasonable, but it should be reasonable in terms of using them cautiously, making sure the patients don't have other risk factors in regards to renal dysfunction, which prolongs the half-life, or hepatic dysfunction.
Okay, great. Well, Jim, one question for you. The TPO receptor agonists have been used for a while now, and the EXTEND study for Eltrombopag has shown that some patients have been treated for up to 6 years. And overall, tolerability was very good. Overall, the response rates seem to be very good, and there are long-term responses for patients who are ongoing taking the drug. The platelet counts seem to be relatively stable. The drug dosage seems to be relatively stable. But there still are certain concerns that those drugs, that Eltrombopag, and we'll come to romiplostim in a minute, but that Eltrombopag could actually damage the liver, and that Eltrombopag could actually lead to bone marrow fibrosis. And I know that you have a lot of experience, and you yourself have presented several times the EXTEND study that is a study that looks at long-term administration of Eltrombopag. Can you talk about hepatobiliary lab abnormalities and bone marrow fibrosis?
Sure. Hepatobiliary lab abnormalities, which usually would mean the transaminases are increased, seem to not be a major concern. They continue to require monitoring, but I think they could be monitored every 2 months eventually. And while there have been issues detected, I think as late as day 981 in a patient, I think it becomes much less of a risk after a while unless medication changes or there's a concomitant infection. But monitoring is required. For bone marrow fibrosis...
Can I come in here? Are there many patients that have to discontinue because of hepatobiliary problems?
Very few patients have to discontinue for hepatobiliary problems. I think between the RAISE study, which was the largest one with 197 patients with a 2-to-1 active drug to placebo, and the EXTEND study, which has, I think, close to 300 patients in it, there were only about 3% of patients have to discontinue. There may be people who develop minor abnormalities. You leave them on treatment and the abnormalities go away. There may also be people who develop abnormalities. You stop the drug, the liver tests return to normal, you start it again, and they don't recur.
Okay, bone marrow fibrosis?
So there's a number of studies that are going to emerge, both Amgen and GSK for romoplastin and eltrombopag are doing studies where they did pre-treatment bone marrows and then did bone marrows out to 2 or 3 years, and those studies are close to completion, and thus far it seems that there's a relatively small number of people who develop any degree of reticulin fibrosis. In our study, which included both drugs and followed some people up to 6 years, we saw up to 20% people develop a grade of fibrosis called MF2. Whether that's significant, whether if they were followed for 10 years they would get into more trouble and more people would reach MF2 is unknown.
Another question that came up during the symposium was switching from one TPO receptor agonist to another. And I myself presented the data of several groups that have published evidence that switching is actually possible both ways, from eltrombopag to romiplastim and from romiplastim to eltrombopag. And although this does not seem to be current usage of those drugs, I think from what we have seen, it may be reasonable to actually change from one to the other if there is lack of effect. As a matter of fact, in a relatively large study of 46 patients from France, those patients who changed from eltrombopag to romiplastim for lack of effect had an 80% response rate to romiplastim, and those patients who changed from romiplastim to eltrombopag for lack of effect also had a 50 to 60% response rate. So it seems that even in those rare patients, because these are rare patients where we have to admit that there is lack of effect, changing to another TPO receptor agonist may be reasonable. Do you have any thoughts on that, Jim?
Yeah, I just would amplify what you said by saying that some of the switches were either for toxicity reasons, not so much lack of effect, or the people, especially on romoplastin, who were cycling with their counts going way up, way down, way up, way down, and then they seemed to smooth out when they took eltrombopag. But totally, I think you're right. The fact that they included all of their patients makes that study, to me, very believable and something of an eye-opener.
Now, another question that has come up is that sometimes with any of those TPO receptor agonists, you still do not get the full response. You have kind of a response and then you lose the response, or the platelet count does not come up to those levels that you really would like to. Do you think, Howard, that adding another drug is a possibility?
Well, there are some case reports, and there's good clinical evidence, at least at our site and experience, that using, example, the addition of low doses of prednisone, or the addition of other agents overlapping that might be immune modulators, azathioprine, mycophenolate, cyclosporin, in combination with either of the TPO agonists can induce responses that were lacking with the TPO agonists alone. So I think combination therapy is not an unreasonable approach. It doesn't fit necessarily into the on-label utilization, but I think it allows some of these patients, and in fact, many times they'll gain a response and you can withdraw the other drug.
I see. And regarding rituximab, Francesco, so you give a patient a course of rituximab, the patient relapses after, say, 2 years. Try rituximab again?
I believe the risk that if a patient has a good response to rituximab and a long-term effect, which can 2 years the long-term effect, if there are no other option, therapeutic option, I think that retreatment with rituximab could be an option because we know that retreatment can be efficacy.
We have about 15 patients where when they relapse and we retreat them, we add dexamethasone and then we add a maintenance regime where we give them a single infusion every 4 months for 2 years. And that seems to be pretty effective because otherwise you can predict that they'll relapse again at about the same time, assuming that they respond the same that they did initially.
Okay.
On the contrary, I want to use maintenance, this sort of maintenance at the beginning, since we don't know for how long the patient will respond. So this could be an option for patients who experience relapse but not frontline.
Okay, that means 4 infusions of rituximab, then see what happens. If patients relapses, then
in a late phase, yes.
Kind of maintenance therapies.
If I can ask a question, in many regions of the world, rituximab anti-CD20 therapy is a very expensive agent. What other agents do you have experience with that seem to have a reasonable response rate for patients that you cannot wean or refractory to steroid treatment?
Yes, of course there are many compounds. There is one that is not very popular, even if it is a very old agent, which is called dapsone. It is an old antibiotic, the category of the sulfonamide, which has a small indication, in particular for some kind of leprosy or for prophylaxis of pneumonia in patients in patients HIV positive. And this agent show activity in a significant percentage of patients with ITP. Let's say that nearly 40 to 50% can achieve response and maintaining upon treatment with this agent.
What's the dose?
The dose is 100 milligrams.
Per day?
Per day, every day.
1 tablet a day?
It depends. There are different tablets with different dosages.
Okay, and any caution? Is there any interaction or anything that you should think of if you give this to a patient?
One important thing we have to do before giving dapsone is to evaluate if the patient has a deficiency of an enzyme which is called G6PD.
Okay.
In this case, it is contraindicated.
Okay, and that is not very common, at least in the Middle European.
Yes.
I think it may be more common for you folks in the US and then in Asia and probably in Central Africa, right?
Yes, it's very rare in Europe and the US. But you must be aware of this because in this case, dapsone can cause an hemolytic anemia.
Yeah. Finally, one last statement. With the TPO receptor agonists now in use, Jim, do you think we won't need splenectomy anymore?
That's a very good question. There's a nice publication in Blood in 2013 from Boyle showing that at least in the US the rates have plummeted terrifically. On the other hand, there's also publications from Italy, among other places, that show that the responses last a long time. So I think we're still not completely clear. I think patients are mainly driving not doing that.
Okay. Well, thanks folks for coming over. This concludes our session today from European Hematology Association in Milan, Italy for eCancer TV. Thanks for watching and goodbye.